Bismillah, walhamdulillah, wassalatu wassalamu ala rasulillah. The title of this lecture is Psychological Aspects of Aging, with emphasis on dental care of the older patients. الله الذي خلقكم من ضعف ثم جعل من بعد ضعف قوة ثم جعل من بعد قوة ضعفا وشيبة يخلق ما يشاء وهو العليم القدير. Aging is a gradual, continuous process. Start from birth through childhood, adulthood, middle age, advanced age, and finally end of the life. In 1978, House divided the patient's psychological response to becoming edentulous into 4 types. The first type or category is the philosophical patient. He is sensible, calm, and rational. The second type is the exacting patient. He resists suggestions. He tries to redirect the doctor's treatment procedure. They want to have extraordinary efforts and guarantee at no additional costs. The third type is the indifferent patient. He is uninterested and lacks motivation, prone to blame the dentist for poor dental treatment. And lastly is the hysterical patient, who is emotionally unstable, excitable, apprehensive, and need professional help. Fitting the personality of an elderly patient is often more complicated than House classification because of the life-threatening diseases, recent traumatic events, and age-related physiological and psychological changes. General psychological impairments are changes that affect person's thoughts, emotions, attitude, and behavior. It can be mild, moderate, or severe, and it will affect the personal life, occupation, social life, and the treatment outcome. The crucial question is, when we get old? The optimum peak usually at the early 20s. After that period, there will be a period of stability, then rapid decline, then the patient will reach the senility stage, which is a physical problems in addition to the psychological impairments. Based on retirement and social role, WHO classified age group into 5 groups or 5 stages of life. From 0 to 17, it is the underage. From 18 years of old until 65, they are the youth stage. From 66 to 79, it is the middle age. And from 80 to 99, it's the elderly senior stage. Over 100 is considered long-lived elderly. Age-related changes, either normal changes or pathological changes. These will impair daily activities, affect self-esteem, affect self-confidence, and coping abilities. In this lecture, the following changes will be addressed with emphasis on sensory changes, cognitive changes, personality changes, and mental health changes. Vision impairment increases with age when we compare 60 years old person with those over 85. There is 4-fold increase in the rate of visual impairments. The visual pathways to the brain is affected, and the cornea also is affected. The pupil of the eye becomes sensitive to light levels and becomes small. Older people need 3 times more light to function effectively, and the lens of the eye becomes more opaque. This condition is known as cataract, which is the most common surgical procedure performed on people above 65 years of old. Depth and distance perception deteriorate with aging, with rapid decline after 75 years of age. And this will affect walking, climbing stairs, and driving. Finally, macular degeneration is the 4th major cause of blindness. Hearing loss can be detected by the age of 30. Younger people adapt better to hearing loss than older persons. Excess earwax accumulate more rapidly in the older people. It is estimated that 13% of the 65 and older suffer from advanced presbycusis. Another 50% have mild to moderate hearing loss. Tinnitus is another problem, affects hearing. The incidence is 3% in younger, 9% for the middle age, and 11% among the 65 years of age. Taste and olfaction. Usually older people complain that food does not taste as good as it was. It was once believed that taste buds number decline with age. Recent studies have demonstrated that taste intensity perception become robust with age. However, the sense of smell decline is greater for taste perception. To increase older people's enjoyment of food, try to provide them with enhanced food odor and spices. Tactile sensitivity. Receptors that detect temperature, position, pressure, and touch sensitivity deteriorate with aging. This is caused by skin changes and less number of nerve endings. Because of the changes in the skin and muscle weakness, it is highly recommended to prepare accessible dental operatories. Pain perception among elderly is similar to the youngsters, but pain behavior is different. Older people usually underreport actual pain and can tolerate higher level of pain. Implications for communications due to sensory changes. It is highly recommended to face the patient while we are talking to them, stand closer, speak loudly, speak slowly, avoid barriers, and try to put them in a quiet office and try to give them the tender loving care by touching their hand or their shoulders. Because of the vision impairments, it is highly advisable to use readable writings written in bold and large prints and using contrast colors like yellow paper with blue ink. Cognitive changes is considered one of the most important and most studied aspects of aging, namely learning, memory, and intelligence. Learning and memory are two cognitive processes that must be considered together. Learning occurs when we are able to retrieve information from our memory. With aging, learning becomes sluggish and slow, because knowledge is not what you know, knowledge is what you remember. Memory can be distinguished into primary or short-term memory and secondary or long-term memory. The capacity of primary memory does not change, but the reaction time does. Whereas a secondary memory is affected when we retrieve the information when we get old. This can cause or result into depression and fear of Alzheimer and dementia among the elderly. The implication for communications due to cognitive changes. It is highly recommended to use structured messages, explain chronologically, fragment the information, and give more time to listen to the patient and more time to discuss and repeat the messages 3 times at least for the old person, and use common language and use multiple modes of communications. Learning styles and resources. Elderly patients can learn if allowed to do it through their own unique styles, using the appropriate resources such as models and brochures, which is very effective. Personality and coping. Personality may be defined as a set of innate and learned traits that influence the manner each person responds and interact with the environment and stressful life experiences, and events. A person may be described in terms of several personality traits, such as passive versus aggressive, introverted versus extroverted, independent versus dependent, adapted versus maladapted. Personality disorders. It can be described as disruption in a person's ability to interact with others. It is more extreme than personality traits, and the prevalence it can be between 0.5 to 3% in any given society. Personality disorders among older people, it will affect their self-esteem or the emotional aspect, and also it can affect the self-concept, which is the cognitive aspect. An example, if a person gets retired, sometimes he have pre-planned for the future, but some of them they get very frustrated and depressed, so they have problem in their self-concept. Also, many elderly people they have paranoia and poor impulse control because of the chronic diseases and fear of death. All of these will cause inappropriate emotional responses. Erikson proposed the psychosocial development throughout the life cycle. According to his model, a person undergoes 8 stages of development or development of the ego. Each stage experiences a major crisis or conflict that it will guide the person to solve the other stage of his life. In the later stages of life, ego integrity or the sense of meaning uh, can be confronted with despair. At this stage, a person should accept the inevitability of mortality and should leave legacy to the future generation. Carl Gustav Jung, the psychoanalytical master, he proposed another perspective. He proposed that aging does not imply maturation and increased wisdom always, because all humans have both feminine and masculine side. The feminine side in the man personality known as the anima, and the masculine side of the woman at the late stages known as the animus. As they age, people adopt psychological trait of the opposite sex. The man becomes passive while the woman becomes more assertive. Jung examined the person's confrontation with death in the last stages of life. He proposed the notion that the person must find meaning to the afterlife and devote serious attention to themselves and be prepared for death. Because if he's not accepting the notion of dying, the person can be ill and weak and frustrated and in deep state of depression. Aging and coping styles. It is highly recommended that the old man should seek the family advices and should always consult his friends and should always keep at least one friend and should seek the help of professionals if they have problem when dealing with others and try to minimize confrontations with others in his work, with his family, children, and the most important thing is to have the religious coping. Personality implications to the dental team. Attractiveness is very important to enhance the self-esteem of the elderly. We have to motivate for oral hygiene. We have to encourage for implant dentistry to give the confidence when eating and smiling. Also, we should give tender, loving care to our patients always and reduce the anxiety as much as possible and always give more time for the explanation. The implications for the Alzheimer patients, we should complete the major treatment early as possible before the case get worse. At the late stages, it is highly recommended to do only emergency treatment and reliance, and we should avoid new dentists to the patient. We should keep one dentist always to see the patient, and we have to introduce ourselves for him every time, and it is recommended to have the patient come to the morning appointment because of the adrenaline and the memory situation. It will be much better. Also, family and caregivers should accompany the patient so they can guide him in case if he lost his way. There are some mood changes that affect an old person, namely anxiety and depression. Anxiety is a general term that describes excessive apprehension. It can be due to panic disorders, obsessive-compulsive disorders, social and dental phobia, generalized anxiety disorders, and post-traumatic stress disorders. Depression is a frequent late-life psychopathosis that affects 15 to 22% of the population. Female are more affected than male at the middle age, while the male are more affected at the late ages of 80s. The good news is that the depression is very treatable. The etiology of depression varies. Patients can have depression because of aging, and this is mainly due to stresses. Reactive depression can be caused by major illness, and some medical condition can cause depression, such as Parkinson's, arthritis, thyroid and adrenal problems, and there is also medication depression. Medicines that can cause medication depression: antihypertensive, digoxins, corticosteroids, estrogen, and antipsychotic drugs. The depressed person, he can feel sadness and grief, hopelessness, emptiness, worthlessness, self-blame and guilt, poor concentration, physical pain and fatigue, and risk of suicide. Furthermore, the depressed person can have changes in appetite, changes in sleep pattern, anxiety for no cause, changes in energy level, and pseudo-dementia. If these symptoms continues for more than 2 weeks, then the patient or the person should seek medical advice. Implication for the dental team with the depressed patient: we should have a good rapport. We should try to build the trust between the patient and the practitioner, and let the patient express their feeling, and always ask for social histories because of the quick life events that take place in their life, and we should update their health in the records. In this section, we will speak about mental illnesses. An example is the bipolar disorder. It is also called manic depressive illness, where a person's mood alternates between extreme of mania and depression. Handling those patients will be alright if they are under medication. However, this type of patient, they are very exacting, very accurate, and they can be a little bit aggressive, but we have to calm them and reassure them, and we should make sure that they should sign the informed consent, because sometimes they change their mind depending on their mood. Other mental illnesses: cognitive and dissociative disorders. These include dementia, delirium, and amnesia. Dementia is actually a variety of medical conditions and illnesses that impair a person's cognitive health. Alzheimer is one type of dementia, which accounts of 70 to 80% of the dementia cases. We can have Parkinson's dementia, we can have vascular dementia, and we can have senile dementia. Dementia affects patients over 80 years of old, 44% among white people, and higher in black people, which can reach 72%, and there is some link with deprivation. and this is inevitable with age. Somatoform and factitious disorders. The person complains from unexplained physical symptoms. He can have blindness temporarily for no reason, deafness, or seizures, and he have constant fear of serious illnesses. Sometimes they do that because of the secondary gain and to get medical attention. Paranoid disorders is another mental illness that is very common among elderly. They have irrational suspiciousness of others. And you cannot blame them for that because in their later stages of life they had been treated bad by others in the street, or they have been stolen in the street or hit. That's why those elderly patients, they have always paranoia and they get scared when they see others. Hallucination, it is sensation without stimulus. They hear things that we don't hear it, and they see things that is unseen. And the main cause of hallucination, either medicine or drugs. Schizophrenia is a serious mental illness. However, it is not common among elderly. Usually it affects the youngsters at the age of 20 to 40, and the people lose contact with the reality. The person, he have delusions and hallucinations, disorganized thinking and speech, and social withdrawal. Most of them, they feel very shy, they have flat emotions, they say nonsense words, and they are not well dressed, and they have poor personal and oral hygiene. The implication for the dental team for the paranoid or schizophrenic patients, expect that we should see more paranoid elderly. We have to explain the expenses of treatment for them, and we should give them alternative treatment plan and ask them to do comparison, and always encourage them to have second opinion. And also we have to communicate directly to them, not to the companion. And the schizophrenic patients, they are not difficult to manage. We should not avoid them. We should treat them. However, dental implants is contraindicated for them because sometimes they will come back and they ask to remove it for unknown reason. Finally, the conclusive remark that dentists, physicians, anybody in the medical profession, he should have a snake eye. He should sense the nature of the psychological impairment and detect it early by asking the question, see their responses, see how they walk, see how they talk, and see how they move their eyes, and expect if there is anything abnormal in their personality. Whenever you notice abnormal personality disorder, advise the patient to seek the help of social worker, psychologist, or psychiatrist. Finally, we should have appropriate rapport and quality communication. Communication issues are like fingerprints. Everybody has them, but no two are alike. So you have to use your experiences and emotional intelligence when dealing with elderly people. وفي النهاية ومنكم من يتوفى ومنكم من يرد إلى أرذل العمر لكي لا يعلم من بعد علم شيئا واخفض لهما جناح الذل من الرحمة وقل رب ارحمهما كما ربياني صغيرا. وهكذا يجب أن نعامل المتقدمين في العمر كأنهم آباء لنا وأمهات لنا. ونشكر لكم استماعكم لهذه المحاضرة.